So good afternoon, everyone. I'm really delighted to welcome everybody to the first of two updates on the Intelligent Intermittent Auscultation programme of work. The purpose of this update is to support midwives in fetal monitoring and education roles who are interested in incorporating this work into the training and education of their midwives in their organisations. This update builds on the information we shared at our previous webinars in January, which are available on the Train the Trainer Hub on the NHS Future platform and also on the AHSN YouTube site. My name is Eileen.Dudley and I'm a Patient Safety Manager at the Oxford Academic Health Science Network, a project lead for this work, and I'll be chairperson for this session. With me are my colleagues Wendy and Christine.
Hi, my name's Wendy Randall. I'm consultant midwife at Oxford University Hospitals.
And I'm Christine Harding. I'm consultant midwife at the Royal Berks Hospital in Reading.
And Alice is kindly helping us with the technical side of this session. It is my pleasure to hand over to Wendy and Christine.
So we're delighted to share with you that even with the challenges that organisations have experienced during the pandemic with training, the number of midwives accessing the e-learning for health training has continued to increase. We've been using this training in our organisations for a few years now, and many organisations have reached out to us to ask about the potential impact in our organisations from this training, and we want to share that with you in more detail today. So firstly, looking at the Oxford data, this slide demonstrates the need that we identified for improvement in 2016-17 that prompted the project to improve IA skills. You can see that since its implementation of this education and training package, that we've seen a marked improvement in outcomes. And in Oxford, we are at 1,107 days and counting between serious incidents where IA was a contributory factor. The most important aspect of this programme is that improved midwifery knowledge and accuracy in IA means that low-risk women and babies are receiving high-quality, safe care to ensure the best possible outcome for their labour and birth. You can see from this slide that there have been improvements year on year, with it becoming increasingly safer for women to birth their babies at home or in our midwifery-led units. The number of babies born in poor condition are small, as one would expect from low-risk women, but we feel this is hugely reassuring that the training and assessment is achieving its ambition for safer care. So appreciate these are early days and the numbers aren't huge, but in Q1 this year, at the start of the pandemic, 295 midwives had completed both the pre-course assessment with the training package and the post-course assessment. From the data we can get out of the e-learning for health system, we can see that almost 50% of midwives passed their pre-course assessment, which should reassure those midwives that the technique that they are using is accurate and therefore they don't need to change their technique. However, it highlights that just over 50% of midwives weren't accurate and would require some further training. After completing the training package, over 3/4 of midwives had an effective technique for carrying out intermittent auscultation, which is a marked improvement and enables organisations to be reassured that their midwives have an accurate skill. It also enables them to identify those midwives who just need a bit more additional support to develop those skills further. We wanted to share with you our experience in terms of training, and you can see that there is a difference between the two units, and that's been interesting. In Reading, they've continued over the last few years to have the training programme alongside the assessment, which accounts for their higher rates of staff being assessed as competent. In Oxford, after the initial year of training and assessment, due to the competing demands for midwifery mandatory training, we were asked to utilise the competency assessment only, and the time that had been previously allocated for training was then reallocated to other topics. However, we saw a drop in competency levels which concerned us. We averaged around 70% of midwives passing first time, compared to 85% the year before. People always go on to pass for the second time. However, it was that initial, why is it that we've seen a change? But since we introduced the e-learning for health programme and had the availability of the education and training resource alongside the assessment, from January this year, we'd seen a 96% pass rate first time, which I'm sure you'll agree is a tremendous success. And our experience demonstrates, we feel at Oxford, the importance of actually having the training programme alongside an assessment of competency. When you ask the midwives about it, because ultimately, you know, they're the ones having those assessments and having the training package, the feedback is that they appreciate the flexibility that the package offers them as it suits their different learning styles. Not everybody is comfortable sitting in a classroom listening to a sound alongside somebody else, so being able to do that at home makes a big difference for them. The training package enables them to repeat the sounds as many times as they need to enhance their skill and knowledge, which, as I said, isn't always possible in a classroom setting. So in practice, if you think about it, a midwife, if they weren't sure about a fetal heart rate, would increase the frequency of auscultation to a point when they're happy. Therefore, we feel the training package is reflective of what happens in practice. So having gone through those first few slides, we thought in this session that we would take the opportunity to discuss the physiology that informs our intelligent intermittent auscultation package. So you can see this slide here, and from the diagram, it's clear that we need to be able to identify decelerations and the significance of these. Traditionally, midwives listened before, during and after contraction, but this isn't recommended in the majority of cases now because it's actually much more relevant how the baby responds after the contraction. Therefore, the training, one of the key lines that runs through the whole training is about being able to listen to that fetal heart immediately after the contraction, as that actually tells you how the baby's coped with it and is much more relevant than what happens during the contraction. So as an example, and I apologise, people always say in intermittent auscultation you're using CTG examples, but it enables you to visualise what we're actually talking about in terms of concepts. So ideally, you'd listen to the baby's heart rate. It should be at its baseline after a contraction, and this blue line would indicate where you would listen immediately after that contraction. However, in this slide, I've used some examples where you can see on the left, baby's heart rate has slowed and is recovering after the contraction, and then on the right that the baby's heart rate has actually risen very quickly above the baseline before settling back to that baseline. So both of those signs can be a warning that the baby is not coping with the stress of labour, and this is why it's imperative to listen immediately after contraction, as a delay of 10 seconds or more can make the difference to what you hear, and you may miss the crucial signs that alert you to the baby becoming distressed. You'll see some slides later in the presentation that will reinforce this point, but it is just important at this point to say that you know, when we've talked to midwives about it and when we've done the training, people are looking at points on their watch. You know, if it's a few seconds before 12 o'clock, they're waiting till 12 o'clock to start, or if it's at 5:02, they'd rather wait till the 12, the 3, the 6 and the 9 before they start listening. And actually that may be a few seconds, or it might be 5 or 10. And in that time, you may miss some of the subtleties. So it is about, you know, your midwives understanding their technique and what they should actually be looking for. So as part of that evolving hypoxia pathway that we've got back up now, you'll see that part of that is the loss of accelerations. But as we know, the loss of accelerations is actually questionable in labour. And therefore, while the presence of the accelerations can be really reassuring, when you think about our national guidelines, the absence of them is of unknown significance. Therefore, the next warning sign of a baby that is not coping with the stress of labour is this rise in baseline rate. And this is why it's absolutely crucial that we're focusing on our intelligent intermittent auscultation skills to focus on calculating the baseline rate. not just recording an arbitrary number that we achieve if we start counting from 1 second to 60 seconds. And we appreciate this is a different concept for some midwives, but IA has evolved, just like electronic fetal monitoring has evolved, to make it a more accurate and safer way of monitoring fetal well-being. So we are aware that there are different methods for assessing the baseline rate. And as we've said throughout, and we make that point recurrently in our presentation, is that if people's rate is working for them, the method that they are using works for them and it's accurate in terms of the facilities we've given you to be able to assess that, then they don't need to change their skill. Not accurate, and that was over 50% of people in our first quarter. We recommend the 15-second block counting method. And we know from the feedback we've received that this new concept is challenging for some. And in response to that feedback and with collaboration with the Royal College of Midwives, we have enhanced this programme. We've incorporated a film which takes into account individuals' learning styles. And I'd like to take you through aspects of this now to demonstrate some of the new things that we've included. So, 15-second block counting method. These are the numbers you would get if you count continuously for 60 seconds. When I count continuously, I mean you count for 15 seconds, and as soon as you get to 15 seconds, you start counting again. And you would get the same numbers if you started counting at 1 second and finished counting at 60 seconds. So as you can see, there is only a slight variation in the numbers in terms of 1 or 2 beats per minute. Therefore, you can be confident with the number that you have that the baseline, and in this case, it would add up to 117 beats per minute. Now, in the majority of cases in labour, this is what you will get. You will count for those 60 seconds, but you'll find that those numbers are very similar, and thus you'll be able to stop counting at 60 seconds and record your baseline rate. However, the issue arises if those numbers aren't similar, and that's what we're going to have a look at now. So in this slide, you will see that you start off with similar numbers of 30 and 28. Again, only that 1 or 2 beat difference in the number. But actually our next two numbers are 36 and 38. Now if we did our 15-second counting method and stopped at 60 seconds, we would get a rate of 132 beats per minute. This would be the same rate you would get if you did a traditional counting method where you started at 1 and continued to 60 seconds. But what does it actually tell you about the baby's heart rate? Why would there be that variance in those numbers? So what we're saying is if you look at those first two numbers, the baseline, if it continued, would be around 120. But if you start to look at the last two numbers, then the baseline would be around about 150. So just that same count of the baby's heart rate, what you're not clear of is where the baby's baseline heart rate is. You're not clear whether you have a steady baseline of 120 with an acceleration towards the end of that 60 seconds, or whether you have that deceleration at the beginning and a higher baseline at the end. So this is why it's really important for us to be aware of these numbers. In this situation, you would count for longer, for 15, 30, 45 seconds, until you're happy that you have similar numbers, and within that you can identify the baseline. So what we did was we continued the count for another 30 seconds, and we could stop there because we achieved two numbers that were similar to the first two numbers. So if you look at the 4 circles of blue, we add those together to form our baseline heart rate. And then we think, well, if that's our baseline heart rate, what are the numbers in red? We can be reassured that we have a baseline heart rate of around 117 beats per minute. It accelerated over 30 seconds and then settled back to the baseline rate, which is a normal physiological response. So I'm going to show you that this was actually what we recorded. So the blue circle highlights the area that we recorded in our simulation suite that identified the baby's baseline heart rate and acceleration. The red line correlates with the number you would have achieved if you counted for 60 seconds. So that was your 132 beats per minute. However, the green line demonstrates the baseline heart rate you get if you listen for longer and you work out what that baseline rate is. Now, hopefully you can see from this diagram that the difference can be anything up to 20 beats per minute between those two rates. And that's very important because we know from talking about physiology of evolving hypoxia that a rise in baseline rate can be significant, especially if it's more than 20 beats per minute. So by listening in for that little bit longer, we're able to ascertain that this is a normal baseline heart rate, and we could record that on our partogram with more confidence that we have a consistent rate. We just want to use another example to reiterate, again, in the majority of cases when a woman is in labour, you are more likely to count 4 similar numbers. Yeah, you can see that there's only the basis of 1 or 2 beats per minute in those numbers, and therefore you'll be able to stop counting after 60 seconds. And in this case, the baseline is 150 per minute. However, let's look at that variation again. And you know, that traditional counting method. So you count for 60 seconds and you stop and record your rate. And in this case, you get 144 beats per minute. If you recorded it in your partogram, you'd be happy. You'd think, well, that's a normal range, and you would continue, perhaps listen again in another 15 seconds. However, if you counted in those 15-second blocks, you can identify variance in that numbers. And again, going back to the previous examples, do you have a normal baseline rate around 120 with accelerations, or do you have a deceleration recovering to higher baseline? So the only way to know for sure how your baby's coping with labour is to listen a bit longer. So again, we continued for another 30 seconds, and we found that there were 4 similar numbers then, which are highlighted in blue. We would get a baseline here of 158 beats per minute. So if you count those slower numbers at the beginning, and then the numbers picked up to this baseline of 158, hopefully you can see that what was actually happening in the beginning was this baby's heart rate was recovering following a deceleration during a contraction. And after the contraction passed, it was taking time for that baby to recover to its baseline heart rate. In that scenario, you would want to increase your frequency of auscultation to ensure that you assess your baby to see if this is a recurring problem. If you were in the first stage of labour, listening again following the next 2 or 3 contractions to get a fuller picture, because it wouldn't appropriate if you thought you heard a deceleration to wait 15 minutes before you auscultated again. Again, this is going back to evolving hypoxia, trying to pick up on the subtleties of this baby so that we can ensure that the woman receives the right care, and that it may be that the deceleration is a one-off, and afterwards you can be reassured the decelerations weren't persisting, but actually if they are recurrent decelerations that are happening, then you need to think of transferring from a midwifery-led unit, if that was where she was, ultimately to commence a CTG to assess fetal well-being. So again, I was going to show you what we recorded in the simulation suite. So you can see that it took time for that baby's heart rate to recover back to the baseline rate. And again, we've highlighted in red, that was the, if you did that traditional count, that was the rate you would have got, versus the green, which is what you get if you use the IIA scales and assess your baseline rate appropriately, and that's the one that gives you the more accurate baseline rate. So when midwives do talk to you about, you know, how do you know my rates is correct, by actually being able to show them that this is what it is, it helps them to see how far out their rate was. And if I take you back to what I was saying before, that in the majority of labours you wouldn't have an acceleration, you know, within that first minute after contraction. Count for 60 seconds, you know, I think that's why you know, we get so few of the poor incidences in poor outcomes in babies in low risk women, but this is a new way to help you identify those babies that are at risk, and we don't want to miss picking those up. So just to highlight again that generally the feedback from midwives is that they have found this new technique enlightening, and I hope that's the case for some of you today. However, they have voiced concerns about trying to put this into practice, especially if you have that woman in the birthing pool, you're trying to hold the sonic aid, palpate a contraction, look at your watch or a clock. And we reassure midwives that in practice, you can actually hold those numbers in your head, because we do it in similar situations, for example, around the time of birth. You know, we all know minutes it was when the head was visible, the head was crowning, the head was born, the baby's born, oxytocin given, all of those kind of things. And we know that it was, you know, 10, 12, 14, whatever it was. And afterwards, we write that down at a time when we haven't been able to write it down, document it in the notes for your records. And the same thing applies with this IA skill. Midwives can retain those numbers over the short time frame. They document them in the records and they add them up following the auscultation. And in reality, we found in our organisations that it becomes quicker the more you do, and midwives find they start adding them in their head. So the slides that I've just taken you through have been included in the training package, and we did this in response to listening to the midwives on the shop floor, to listening to the Royal College of Midwives. And so now, in terms of other feedback that we've had, that we've addressed in some of the enhancements we've put in place, Christine is going to take you through the feedback from leads within organisations about accessing results and supporting staff.
Thanks, Wendy. So we'd like to take you through how to access the trainees' activity. So in order to be able to do this, the learner needs to give you permission to view their results when they register for the programme. We've put together a step-by-step guide to show you how to do this, and that's available on the Train the Trainer Hub, which Eileen is going to talk about in a moment. When you log on to run a report, you need to select the admin drop-down menu and click on Reports. This then gives you a list of reports that are available, and the one you need to use is the user permissions report. You can then put in the dates you want and select the IIA programme before running this report. You get the option then to download the report in 3 different formats. We recommend that you click on the CSV file. So the reason it's that we recommend the CSV file format is so that you can then manipulate the data. So these are the headings that you will get. The username is usually their PIN number if they're a qualified midwife, but you'll also be able to identify them by name. The date and time that they started and ended their activity. The activity duration. Now this is really important because it's possible that this column might show someone's session as being very, very short. For instance, as we'll show you in a moment with some examples, 0, which suggests that they were probably having a login issue, and therefore that part of the data can be ignored. The activity status will be either passed, failed, and not complete. And again, we'll talk more about that in the next few slides. The activity score is the mark that they've achieved for either the pre-course assessment or the post-assessment. This column will be blank for the times the midwife has dipped in and out of the session and not completed it from the beginning. The name of the session will either be Intelligent Intermittent Auscultation for the pre-course assessment and learning, or Intelligent Intermittent Auscultation post-assessment. So I've got a few examples on this worksheet to show you. We'll talk you through how to manipulate the data so that you can get some valuable data out. So Alice is just going to load that up now, and we'll be able to click it through as I'm talking. So if we look at user 1 first then. So to start with, and I must just say that these examples that I've got are all from one single user, and I've taken them from the reports that I've run here in Reading. So they're all live situations. So if we look at user 1, to start with, I'd hide the columns that you don't need. So the course always is the same because that's the course that you've run the report on. So I would hide that just to get it out of the way. Under the heading, you can see that we've got information for both the IIA session, which includes the pre-assessment, and the post-assessment. The next column, moving from right to left, shows the score, and you'll see there are multiple times that the midwife has scored 50% on their pre-assessment. Now, they only need to do this once, and therefore the multiple entries that are stating 50% are from that one first attempt. In the column activity status, you'll see there are multiple entries for IIA session, and all but the last one say not complete. So this is probably because the user has been having trouble getting into the system to confirm that they've completed all the elements and ultimately giving them a certificate. And we know that's been one of the issues. And it's something that we've been working with eLearning for Health to change. It may also be that the midwife has left their computer and it was timed out, and therefore they needed to log back on again. If you're keen to use this information to find out how many times the individual has accessed this learning, it's really important to look at the column with the time in it. The entries with 0000 are anomalies to do with the login process and not relevant. So it's really important to ignore those. So if we filter that column and Alice takes out those 000 entries, we then get a better picture of this midwife's activities. So she spent 40 minutes doing the pre-course assessment and the learning and got a score of 50%. She then did the post-assessment and wasn't successful with a score of 80%. She repeated the assessment again but didn't complete it. And again, we don't know why she didn't complete it at that time. On the third occasion, she completed it and scored 85%. She then revisited the learning, probably because it wouldn't give her a certificate, and spent another 10 minutes and then another 51 seconds before it finally recorded that she had completed the course. So as I said, we've been working with eLearning for Health to make it easier to record that the programme has been complete, and therefore hopefully you won't see so many of these incomplete entries. So we'll just go through user 2. This midwife has had less attempts. Again, you can ignore the first attempt when the time says that it was 0000. So she spent 44 minutes on the pre-course assessment and achieved 67% and doing the learning at the same time, and then did the post-course assessment in 18 minutes and achieved 95%. Let's look at user 4. Thanks, Alice. So again, if we filter out the 0000 minutes, we can see that this person did the pre-course assessment and learning on the 16th. They achieved 67%, but didn't complete all of the training, which is why it's shown as incomplete. They went on to do the assessment and achieved 80%. A week later, they went back to the training and this time completed it. The score for the pre-assessment is the same because they'd already completed that and they didn't need to do it again. They attempted the assessment again but didn't complete it. It may be that they moved away from their computer and it timed out, or they simply stopped partway through. Finally, they completed the assessment and scored 100%. So it's important to know that when the programme logs you out, there's an option to restart from the beginning or from where you left off. And that probably accounts for some of the shorter times spent to complete the training. So it's likely that the last 10 minutes taken to complete the assessment was the individual logging back on from where they'd got to and just finishing off. So using this data, you can identify the individual's results within your organisation, as well as be able to look at your organisation as a whole. And importantly, we can see from these examples, and you will be able to identify from your reports, the improvement in a midwife's accuracy. I'm just going to ask Alice to close that workbook down now, and we'll go back to looking at some of the slides. So you might be concerned about the numbers of midwives in your organisation who are unsuccessful. This shows our data from Q1 this year, which incidentally coincided with the start of COVID, and it shows that 75% were successful within 2 attempts, which is fantastic considering that nationally this is a completely new concept to some midwives. Ideally, we recommend that midwives seek a one-to-one conversation with their fetal monitoring lead or PDM if they're unsuccessful. However, it's human nature to want to keep trying until you get it right. Using this data, you can identify those midwives who are having multiple attempts and can approach them proactively to discuss the difficulties they may be having. So I'm going to hand over to Eileen now, who's going to talk through the resources available on the Train the Trainer Hub.
Great, thank you, Christine. So we've set up a Train the Trainer Hub on the Future NHS platform because the platform is secure and it's easily accessible for NHS staff. So if you're not a member and would like access, please email me. So on the platform, you'll find links to the masterclasses, which we recorded in January this year. So you can watch those webinars again. There's another assessment and answer document, and we also have the frequently asked question document, which we compiled after the January webinars. There's a discussion group, and I would encourage you to use it because it offers you an opportunity to problem solve and learn together as practice education staff. I check in at least weekly, so you will receive a prompt response from me. If there's anything I can't answer, then I always catch up with the 2 midwives, Wendy and Christine. I'm also aware that education teams are frequently reorganised due to, internal issues. So if you have new members in your teams who would benefit from access to the platform, do please let me know and I'll make sure that's sorted for you.
So Wendy and I have been using this training in our organisations for quite some time now, and we've identified a few hints and tips that you may find useful. First of all, you need to make sure that you send your midwives information about how to register prior to the day they're expected to complete this training. If they haven't already got an account with eLearning for Health, they'll need to register using an NHS email address or through an Athens account. Once they've registered, they can then access this training anywhere. In our experience, midwives have waited till they've got home, sat down to do the training, and then realised they needed to register, but weren't able to do it because they didn't have access to their NHS email address. So it just depends what things are like in your organisation. Encourage them to give you admin access when they register for the training so that you can run your reports. Hopefully it's clear within the programme. However, it's really important that they work through the programme logically. They need to be in a quiet environment with access to a clock with a second hand, as they would have in clinical practice. Our experience shows us that it's really challenging to do this while using a digital timer, as if they were looking at their phone, for instance, and we wouldn't be doing that in clinical practice. We're aware that some of the sounds are not as clear and authentic as we would like. Some of this we found out seems to be down to the individual devices that you're using for the training. However, we are working with the simulation team to try and improve the quality of the sounds. Please encourage your staff to make a note of the answers they get wrong. We purposefully haven't included the correct answers in the assessment so that these can't be recorded and shared, but that means they need to tell you what answer they gave for you to be able to help them identify where they went wrong. If users have any difficulty assessing the programme or it doesn't seem to be working as expected, there's a support email address for them to contact eLearning for Health. In my experience, the response has been very prompt. The help desk are very keen to receive screenshots, which will help them to resolve your problem. It's a good idea to request the midwife sends you or shows you evidence of their assessment. Of course, you can just rely on running your reports, but that will only allow you to see those midwives who have given you permission. We strongly recommend that you arrange for your fetal monitoring lead or PDM to have a one-to-one with anyone who's not successful. You can then use the resources in the Train the Training Hub to identify why they were inaccurate and to help them. There's another assessment that you can then ask them to do. They can, of course, go back onto the programme and do the learning again and practice as many times as they like. It's important that you discuss within your organisation how you can support those who are not successful. In our organisations, midwives do not work in the intrapartum area if they're unsuccessful until they've had a one-to-one and demonstrated competency. As we've said, they're not big numbers, and this process has been very manageable in our organisations.
While the majority of feedback has been positive and reassuring, we want to focus on the things that we can do to make it better. Some of it, as Christine's alluded to before, are computer glitches, and we do encourage the midwives to contact the support team for the programme. However, we have had some feedback about the pre and post assessment. So for your information, the pre-assessment is actually a measure for us on the training programme, as it gives us a benchmark of how accurate individual skills were before accessing the learning package. We can then compare the pre and post assessment scores for evidence of acquired learning. In terms of the post assessment, we don't provide the correct answers deliberately, as we're aware from our experience with other e-learning packages that it is possible to screenshot correct answers and share these with colleagues. And we didn't want to enable that practice to occur. We want it to be a true assessment of that midwife's skill and not the skill that somebody else has sent to them. So we do appreciate the feedback, and we are having conversations, as we've alluded to throughout today's masterclass, that we're working with e-learning for health very closely to make improvements where we can. And obviously we've listened to the feedback from the Royal College of Midwives as well, which has been really valuable, ensuring that we're hearing everybody's voices.
We feel the positive feedback speaks for itself, and positive comments are by far in the majority. We appreciate this training package is challenging for some individuals, and it's important we support them and help them to see that this change in practice is a positive step, as we all want to do our best to provide safe and effective midwifery care.
I just really would like, from the perspective of the Oxford Academic Health Science Network, from the two consultant midwives organisations, just to thank you very much for supporting the webinar and taking time out in your lunch break to come along.